Could you please explain that and how it's relevant to addressing uterine fibroids?
So myomectomy is one of the procedures we don't really like in IVF setting because they can cause more problem than solution. We don't really recommend doing myomectomy unless we really have to. So we have to recommend myomectomy when we cannot access ovaries because of multiple large fibroids. So simply we cannot do IVF because we can't get eggs from the ovaries. So then we have to offer or recommend myomectomy. So the reason myomectomies can cause more problem is because they are not very notorious for causing severe pelvic adhesions, scar tissue after the surgery. So after myomectomy, whether it's open myomectomy or laparoscopic myomectomy, you have a bleeding from the cut area of the uterus, and that bleeding into the inside the pelvis causes a lot of adhesions. So we don't really like adhesions in IVF, especially when it comes to collecting eggs. Because of adhesions, so ovaries usually get pushed up and plastered up in the abdomen, and they may be difficult to reach in IVF cycle after the myomectomy. So when you do IVF, not always, in a lot of patients, when you do IVF after myomectomy, its ovary is so high, it is one of the ovaries high because of scar tissue, and you cannot reach that ovary. And also, when ovaries entrapped inside adhesions, like in frozen pelvis type adhesions, then that ovary doesn't produce as many follicles because there's no space. So if patient needs myomectomy, they have to have a myomectomy if there's no access. But if patient needs to have a myomectomy for implantation, let us say there's multiple large fibroids distorting the cavity, they need to have a myomectomy. If they need to have a myomectomy for implantation, we ask them to do IVF and freezing of banking of embryos first. So we ask them to do number of IVF cycles, bank up a lot of high-grade embryos, 6, 7, 8 high-grade embryos first, then do myomectomy, because then we don't need to worry about scar tissue formation inside the pelvis, and we don't need to worry about reaching ovaries. Yes, even if you have adhesions, fine. We already got embryos now, only we're concerned about transfer in implantation. So, and that's very important to emphasize to the patients. If you need to have a myomectomy, you need to understand your ovaries may not be accessible easily during IVF. After the procedure, this is why you need to do banking of embryos first. So, myomectomies also can cause intrauterine adhesions. So, myomectomies can cause adhesions outside the uterus, which is inside the pelvis. Myomectomies can cause adhesions inside the uterus, which is inside the cavity, and that's called Asherman syndrome. Especially if you have an undetected breach into the uterine cavity during the surgery. So during the surgery, the surgeon should describe whether there was a breach into the cavity. Let us say in the myomectomy, open or laparoscopic, the cut happens from outside the uterus. You go inside the wall and you shell out the nodules of fibroids. So if fibroids are sitting very close to the endometrial lining, you may have a tear inside the uterus, which means cavity has been breached. So if cavity has been breached, that needs to be managed. First, it needs to be repaired during the myomectomy. Second, after myomectomy, you need to do second look hysteroscopy. You need to, after next month, you need to look inside the uterus with a camera to make sure that you don't have any scar tissue formation. If you're having scar tissue formation, which is the beginning of Asherman syndrome, you need to disrupt and cut those scars and look again to make sure you don't have a scar tissue formation or Asherman syndrome after breach in myomectomy. So if you don't have a breach, then there's no risk. But if there has been breach, that needs to be detected and managed and monitored to make sure endometrial lining is growing fine. So for these two reasons, we don't really like myomectomies. But if you have to do myomectomies, yes, we need to do myomectomies. If you're doing myomectomy for implantation, then you need to bank embryos first. If you need to do myomectomy to access ovaries, then yes, you need to have a myomectomy. But you need to really ensure there has not been breach into the cavity. If there has been breach into the cavity, that needs to be managed and monitored to make sure you don't have Asherman syndrome. So, and also another thing, important thing about myomectomy is to remove all fibroids. you can have a multiple fibroids, 20, like more than 20 small, big fibroids. So one of the problem myomectomies can cause is if you don't remove all fibroids, if you have some leftover for fibroids, and those fibroids can keep causing problem. Mainly distortion of the uterus anatomy, again distortion of the cavity, pooling of the fluid in the cavity. So generally in IVF setting, we have to be very we have to provide very individualized advice, individualized management in patients needing myomectomy. We should not just simply do myomectomy like in gynecology setting. In gynecology setting, myomectomy is really indicated to reduce heavy periods. But here we're more interested in accessing ovaries and more interested in improving implantation. So that's why it is not simple intervention when it comes to IVF in myomectomy.